remember, you're going to have AP and PA both, and you're going to have AP and PA axials, and they're going to show you totally different things, right? So the PA and the AP, we'll take a look at the images here in a bit, but remember that the orbits on the PA and the APs, that's straight AP and PA, that's not axial. The orbits are going to look kind of pirate flag eyes, you know, they're more, they kind of have to me, they kind of have a little bit more of a sinister look, whereas once you get into the Caldwells are more rounded and they just don't look quite as spooky as what they do on the PAs and APs. So the textbook says almond-shaped eyes, so they're more squished. They're not as round on the PAs and the APs, so straight AP and PA. And what we're looking for there is frontal bone. We prefer to shoot PA because we don't get the magnification of orbits, and also we don't get the eye dose. Remember, using the head as a filter. So we prefer PA. Can't always do PA if the patient's on a backboard in a collar. We can't flip them over, so we have to do AP and just have to take what we can get. So we prefer to do PA for that reason, but sometimes we have to do AP. So the petrous ridges, or the reason the eyes look the way they do is because the petrous ridges are completely filling the orbits. And some of your test questions may say the petrous ridges are at the top of the orbits. And what that's referring to is the top of the petrous ridge at the top of the orbit, which means you fill the orbit, right? So it really means the same thing. And then we get into the PA and the AP axials, and we're going to kind of separate those two out, the AP and the PA axials. So we have two PA axials. If you remember, we've got one that is Caldwell, and the Caldwell utilizes 15-degree caudal angulation. It's what we refer to as a general survey view. And what that does is, because of the distance, the distance difference between the petrous ridges and the orbits, petrous ridges are further back in the orbits. The orbits are going to be as close to the image receptor as possible. So with that 15-degree caudal angulation, the orbits don't move much, but the petrous ridges do, right? So it pushes them down into the lower third of the orbits. So that PR is petrous ridges. Petrous ridges lower to 1/3 of the way through the orbits. So we get that more rounded appearance to the petrous ridges. So we're going to take a look at some images here in a minute. I think I might have mentioned it last Monday, but we'll talk about the angulation as we increase angulation, what we're going to get then. All right. So, but the other PA axial is going to be the Haas, and the Haas, how you're going to tell the difference between them is what are you looking for, right? What the angulation is number-wise, and what the angulation is direction-wise. So the Caldwell is always going to be caudal. All right. So Caldwell caudal. And the Haas is going to be cephalic. So the Caldwell, we're still kind of looking at the frontal bone, but we can see a little bit more stuff, right? So the Caldwell, general survey, frontal bone-ish. The Haas, though, is going to be the reverse of the more common view that we're going to take, and that is it's going to be the reverse of the Towns. So what we're going to utilize with the Haas is a 25-degree cephalic angulation. And because we're looking at the occipital bone on the Towns, if the Haas is a reverse of the Towns, then naturally we're going to be seeing the occipital bone there too. So what we're going to see on the Haas that we're not going to see on the Caldwell, for the most part, is going to be the start of the foramen magnum. And what we want to see is a couple of things. We're going to see a portion of the foramen magnum. We're going to take a look at what happens if we increase the angulation on the Towns, not necessarily the Haas, but change the angulation on the Towns, what is we're going to see here in a bit. But what we're going to see is a V shape of the petrous ridges, right? We're not going to see any orbits at all. The orbits are completely pushed down into the facial bones, or really, I guess the petrous ridges are pushed up above the orbits, I guess is a better way to say it. So the Haas, again, reverse Towns, we're looking for the occipital bone. It's 25-degree cephalic angulation. We're going to see the foramen magnum and a V shape to the petrous ridges, right? And you might be able to see the lambdoidal suture as well, if the contrast is right. So those are your PA axials. PA axial caudal for Caldwell, and then cephalic for a Haas. And then if we can't shoot PA axial, then we're going to do AP axial. Again, the Towns is more common of the two because it puts the occipital bone closest to the image receptor and increases sharpness for recorded detail of the occipital bone, right? So what you're going to be seeing on the Towns, question-wise, is one of two different angulations, either 30 or 37, and we talked about that last week, and that the difference between those was basically how well can the patient position themselves for the baseline, so to speak, Towns, right? So if they can put their orbital meatal line perpendicular to the image receptor, your angulation is 30-degree caudal. Through the occipital bone, really through the foramen magnum, we're going to see the foramen magnum. We'll be able to see the posterior clinoid processes inside of the foramen magnum, right? So Towns, you angle down, like go downtown, right? Down for the Towns. So you angle caudad, 30 degrees caudad for the Towns, as opposed to the reverse of the Caldwell, we're going to angle 15 degrees cephalic, right? So any Caldwell is going to have that 15 degrees. If it doesn't have 15 degrees, it's not a Caldwell by the textbook. Again, some of your, if you find yourself in a position where you're shooting skull work, the technologist that you're going to be working with may call something else a Caldwell. But just know that according to the test, 15 degrees is your Caldwell, right? So all the way through the registry, 15 degrees is your Caldwell. All right, so also with the AP of the Caldwell, the only difference between the AP and the PA is loss of sharpness recorded detail in the orbits and the magnification of the orbits, right? Everything else is identical. Entrance point and exit point notwithstanding, what you see is the same. So the 37-degree Towns, we use that whenever the patient can't tuck the chin enough to put the orbital meatal line perpendicular to the image receptor. So what we have is an infraorbital meatal line perpendicular. And the difference between the orbital meatal line and the infraorbital meatal line is 7 degrees, right? So we just increase the angulation to 37 degrees and you're accomplishing the same thing. So that's the thing that we're going to do throughout the semester is what if the patient can't get their orbital meatal line perpendicular or parallel to the image receptor, then we're gonna do what? If the patient can't accomplish something, positioning wise, what do? We compensate with angulation of the central ray, right? So, so then again, the things that you're going to look for is Towns and Haas. You're going to look for the V shape of those Petrus ridges. You're going to look for questions that mention the foramen magnum and don't mention the orbits. What we're going to look for difference between the PA and AP and the Caldwells is the position of the Petrus ridges inside of the orbit. 15 degree pushes them down in the lower third, right? So naturally, completely fill the orbit, lower third. If we increase the angulation, then they're just going to keep on moving, right? So then let's take a look at some images. Any questions on all that? All right, so then what we have here is a comparison between the PA axial and let me enlarge this so you can see a little bit better. Nope, can't do that yet. Come back out of that. I'll enlarge it. Really stretch it out and make it look funny. All right, so difference between the PA and the Caldwell. Again, we've got the Petrus ridges all the way up here. Remember, that's the lesser wing of the sphenoid bone. That's not the Petrus ridge coming out laterally here. Petrus ridges are coming straight back this way. So that's the top of the orbit, Petrus ridges, and then you've got a more open orbit for the Caldwell. Right? Is it PA? Is it AP? I don't know. I have no idea. Can't tell. Only way you'd be able to tell is if you had a PA and an AP of the same patient side by side to be definitive to tell whether or not it is AP or PA. So again, the orbits, you know, you say the orbits are almond shaped, but they're just so occluded, so to speak, with the petrous ridges, you can't clearly identify the edges of the orbits in the PA and the AP, right? So if it looks like, you know, a human skull, but you can't make out the orbits, guess what it probably is? Is it this one? No, you can make out the orbits there. So it's not the Caldwell, it's going to be the PA or the AP, either one. So if you increase the angulation, so this is, you know, maybe a 20 degree, if it was 25 degrees caudal, then the petrous ridges should be completely out of the orbit. Now, if you, let's see, if you look on page 38, under central ray, far right column, so what you see is center the image receptor of the central ray show the superior orbital fissures direct the central ray through the mid orbits at the angle of 20 to 25 degrees caudal. Okay, so that's just increase in angulation, and this is what you get. If you increase more than that, you're going to direct you're going to project the petrous ridges below the infraorbital rim. They're going to be completely out. So then it goes on to say to show the rotundum foramina direct the central ray to the nasion at an angle of 25 to 30 degrees caudal. So you just increasing your angulation and project those things lower and lower and see more features inside of the orbit. So, you know, I think I started this last week with you may never do any skull work, right? Just because everybody's going to go to CT. If there's something going on inside of the head, they need to see, you know, really what's going on inside of the head rather than just seeing the bones. So if you're not likely to shoot a skull series, you're definitely not likely to shoot any of these. So just file it away. You know, I don't want to make it sound like this is, you know, the semester is going to be a waste of time, because you got to have this all the way through the registry, right? And some of y'all may find yourself working in a small rural hospital that doesn't have CT staff 24 hours a day, 7 days a week. So some of y'all might eventually shoot some of these. So it's good to cover it, but you know, again, I don't want to put a negative spin on it, but most of y'all probably flush this after the registry. So increase your angulation, pushes the petrous ridges down a little bit further, and you'll see something at the bottom of that central ray thing. It says the Waters method presented in sinus radiology section is also used to show the rotundum foramina. So we're going to look at the Waters later on when we get into sinuses, and what you'll see is a commonality between like a 30-degree caudal angulation on central ray for Caldwell and the one of the modifications for the Waters, and specifically what you're going to see is similarity in position of petrous ridges, but distortion of the skull with the Caldwell versus the Waters, because we're going to position the patient's head for the Waters, position central ray for the Caldwell. Okay? And the other thing is in our Towns method. All right, so remember, this is Towns. We don't see the orbits at all. We got the V shape to the petrous ridges. And the skull looks really stretched out, right? So if we were to include the entire skull with the facial bones, it looks like it's about 2 feet long. It's really, really stretched out. And if you're a fan of old horror movies, Alien, it really looks like the alien skull. It's that stretched out in appearance. So you might have a tendency to say, wait a minute, I can't see the orbits in that, and I also can't see the orbits very well in that. Yeah, but do you see the foramen magnum in this? Not really. You're seeing sinuses, right? But as opposed to this, that's a nice round foramen magnum. Okay, so V-shaped, no orbits, big hole in the middle of the head, Towns. Okay, Towns or Haas? I don't know. They could have put this in here as Haas and we wouldn't be able to tell the difference. And again, unless we saw PA and an AP of the same patient side by side. So you really can't tell the difference between them. Okay. V-shape, hole in the middle of the head, no orbits. We've got the Towns or the Haas. All right. So now I want you to look at. Let's see, where is the Towns? Okay. So if you look on page 48, well, we'll start on page 47. Just kind of, in your mind, lock in that image on page 48, same picture that we had up here. I'll go ahead and put that back up so that you can see it. All right, so looking on page 48, spell this out a little bit better. Okay, so under pathologic condition or trauma, to show the entire foramen magnum and the caudal angulation central ray is increased from 40 to 60 degrees. Okay, so look at the images on page 48 and then glance back up here at this. Again, what we have is a little bit more of an oval shaped here where it's wider than what it is long, but if you look on page 48, it's longer than what it is wide, right? Mm-hmm. So in this case, again, I think we might be looking at a skull phantom. I don't know that for certain, but the posterior clinoid processes should be inside the foramen magnum on the Towns. But once you increase your angulation all the way up to 40, even 60 degrees, and this is assuming that you've got your orbital meatal line perpendicular, then even the foramen magnum appears more elongated, and those posterior clinoid processes just projected out. So again, test question, to see the entire foramen magnum, you need to increase your angulation to a minimum of, says right there on page 48? 40, right. So you need to go to 40 at least, maybe all the way up to 60 for the foramen magnum. You see the foramen magnum, you just don't see the whole thing. Okay? Any questions on those? And the only thing left is the Schullers, and then just kind of a little bit of a wrap up of all the projections we're going to see over and over and over again this semester. So the SMV, very, very useful view that shows a lot of stuff. And we've talked about the Towns and the Haas showing us the occipital bone. And you're going to have a tendency on the test to select for a specific question that asks for the cranial base. You're going to have a tendency to want to select Towns or Haas, but according to the textbook, Schuller's shows us cranial base. All right, so what the Schuller's does, the positioning for the Schuller's, is completely different than everything else. It's referred to as an SMV projection, and that stands for submento. So where's your mental point? Under your chin, right? Vertical, or submental vertex projection. So what that means is our central ray is going to enter under the chin and exit the top of the skull. All right, so it's to position for the SMV, we're going to see it for facial bones, sinuses, skull, a little bit mandible, not so much, but what we're going to do is we're going to extend the patient's chin until the infraorbitomeatal line becomes parallel to the image receptor. Okay, so central ray is going to be perpendicular to the infraorbitomeatal line and the image receptor if you can get the patient have their chin extended far back enough. What it's going to take is, if the patient's on the table, then what you're going to have to do is you're going to have to build the patient up and kind of hang them off of what you build them up on. So if you've got one of those 4-inch sponges, those hard, they call it a sponge, but it's really hard, right? Put the patient on it, possibly some towels or sheets also, and have them lean back and put the top of their head, the vertex of their skull, on the image receptor and try to put the infraorbital meatal line parallel to the tabletop. All right? Yeah, it's a lot of fun. Your other option is to have the patient, granted, this assumes the patient isn't in the hospital because they fell and they hit their head, right? If the patient can assume the position, let's say you're doing sinuses, it's easier to do with the patient in a chair, and I don't mean a stool, right? I mean a chair with a back, and it could be a back with wheels on it, but if the patient's on a just picture this happening. It's funny in concept. It would be tragic in reality. But let's say you put the patient on one of those stools, roll around stools, and you put them, on the stool, and you have them lean back, and they put their head on the image receptor. They're leaning way back like this. They don't have a back on the chair because it's a stool, right? What's going to happen?
Bye.
Well, you were doing sinuses, now you're doing skulls, because the patient's going to bite it, right? They're going to fall out off of the stool. It's going to roll right out from under it. So if you do it upright, don't stand them up and do this, right? Put them in a chair, not on a stool, and have them extend their chin back. Just have them slouch, is the easiest thing to do. And put the vertex of their skull on the image receptor, right? Put the infraorbital meatal line parallel to the image receptor, and the central ray is going to be perpendicular. So what if you do all that and the patient still can't get their chin back far enough? Angle central ray, right? So regardless, in an ideal situation, you want the infraorbital meatal line parallel to the image receptor. But if the patient can't do that, then you're going to angle the central ray perpendicular to the infraorbital meatal line. So again, perfect situation, central ray is perpendicular to the image receptor, infraorbital meatal line is parallel to the image receptor, and that puts the central ray perpendicular to the infraorbital meatal line. If the patient can't do that, then what you want to do is angle the central ray perpendicular to the infraorbital meatal line, regardless of what that orientation is to the image receptor. Okay? What that should do, I'm going to take the top of the skull back off. What that should do, unless you got somebody with some real crazy anatomy, is it should put the mandible, okay, so this condylar process of the mandible, it should put it anterior to the petrous ridges, just a little bit, okay? So if the chin is tucked, what that's going to do is it's going to project it into the petrous ridges. So on positioning, what you're going to do is you're going to extend the patient's chin back far enough, and you'll start to see the nose sticking out, right? And then you'll just start to see the cheekbones. And once you get to those cheekbones, you're pretty much there. You'll see the soft tissue of the cheekbones kind of puffing up on either side of the nose, and you're pretty close to where you need to be at that point. So on our evaluation, what we're going to see is, or on our image and our evaluation, what we're going to see is this, okay? So we got our teeth way out anterior, and we got our petrous ridges here, okay? And you might look at that and you say, oh, well, that kind of looks like a V shape too. That's an inverted V. It doesn't count, right? So foramen magnum, you see that as well, but in the towns, you're just not going to see the teeth projected out in front of the frontal bone. So mandible, condylar process of the mandible, foramen magnum right in the middle, and it's really more rounded, and petrous ridges should be posterior to the condylar processes of the mandible. Okay, so we're going to see this again when we look at the facial bones. We're going to look at it again whenever we're looking at. We've got several. Schuller was a busy fellow or lady. I don't know whether it's a man or a woman, but we're going to look at it again when we see the sinuses. We're going to talk about it again, and the only difference between each one of these is going to be central ray location and collimation. So our central ray is going to pass through just anterior to the EAM. All right. So probably the most common positioning area you're going to have on this is tilt of the head. It's going to be, you're going to be so focused on getting that infraorbital meatal line perpendicular or parallel to the image receptor that you're going to wind up with rotation. And this one actually has a little bit of rotation. You see the distance between the lateral portion of the skull on this side and that side. A little bit of, it's not the same. And what causes that is tilt of the head. So, pretty much how we're going to use this to see facial bones is by tilting the head just a little bit so that we can see the zygomatic arches. But that's kind of what you're seeing is a little bit of a tilt of the skull. So it's still good. I wouldn't repeat that for that, but it's, that's what you're going to be looking at. So any questions on this one? I've tried this one in every possible way, and really sitting up in a chair is, in my experience, the easiest way to do this. We used to do a lot of facial bones with these, and it's, I'm kind of telling myself a little bit here, but I've tried these with the patient standing up and leaning over the x-ray tube with a film over the top of their head to try to get the zygomatic arches without having to, have the patient lie on the table and extend their chin way back. Pretty much what they did was they took the x-ray film in a cassette, pointed the x-ray tube straight up at the ceiling the best I could and just had the patient lean out over it. Don't try that. It didn't work. It didn't even come close to working. It was awful. So again, in my experience, the easiest way to do, and the safest way to do these is put the patient in a chair up against the wall bucky, providing the patient can tolerate it. So what we're going to see over and over again is we're going to see some variation of lateral on just almost everything that we do. We'll see laterals, we'll see lateral of the nasal bones all by themselves. We'll see axial laterals, which means an angulation on the lateral. We'll see axiolateral oblique. So we'll see some sort of lateral pretty much all the way through to the end of the semester. And with the exception of the axiolateral oblique or the axiolateral, the position is going to be identical. That is going to be, the infraorbital meatal line perpendicular in front of the image receptor. Only difference then is going to be central ray location collimation. What anatomy do we want to see? We just need to see the facial bones. We don't need to see the entire skull, so our positioning is going to be more anterior. Nasal bones, the only thing we're looking for is the nasal bones, so positioning is going to be the same. We're just looking for a bone that's, about the size of the end of your sharpened pencil, right? So we don't need to see the entire skull. So AP and PA, we may see some variation of. The Caldwell, we're going to see on everything. In Towns, we're going to see Haas. File it away and just remember all the way through the final that the Haas is a reverse of the Towns. Remember the Towns, Haas is a reverse of the Towns with a 5-degree difference in angulation is pretty much what we're going with there. And as Schuller's, we're going to add some Schuller's to it. So we're going to use this Schuller's, the SMV Schuller's, but we're going to add some other ones to it as well. So that's the rest of our semester right there. With some other things, there's some waters and other things we're going to throw in there as well. Okay? Any questions?